Ali, I'm assuming you're on.
I am on. Good morning.
Good morning. I'd like to welcome you all to the May 18th PEB board meeting. And I'll go ahead and call this meeting to order. My name is Kimberly Hendricks, the board chair, and I'll do a roll call. We have Kate Nass is excused and Dana Harganani is excused. Kim Harmon?
Yes.
Good morning. Sean Parkman?
Good morning.
Good morning. Mark Perlman? Siobhan Martin?
Hello, good morning.
Good morning. Jeremy Vandehey? Is Senator Betsy Johnson attending today? Representative Andrea Salinas? All right. Okay, so I don't think we have a quorum, do we, Ali?
We are one short, so we'll need either Mark or Jeremy to show up. So we'll need to push the minutes off for a
right. So
bit.
we can go ahead and hopefully Dr. Bachman has joined us, and we'll go ahead and move forward to our COVID updates from the carriers.
Great.
Good morning.
Good morning, and we have a special guest today. I think that this presentation is to be done by one of our COVID experts who's been doing amazing work pulling all the parts of COVID prevention and our vaccination program together. Her name is Michelle Teeples, and she'll be joining with Sapari for the conversation today. Is Michelle available?
I'm here.
Fantastic. And Sapari?
Yes, this is Sapari.
Great. I will turn it over to you two.
Thank you. Okay, I will start us off. Wanted to give everyone a quick overview of our vaccination counts. For Kaiser Permanente Northwest members, we are about 60% of our members are vaccinated with at least one dose. And we are soon going to be starting vaccinating younger members, 12 to 15 years of age. For our PEB population, our vaccination efforts are 54.5% of those members have been fully vaccinated or in the process of being vaccinated. And that represents about 33% have been fully vaccinated, and 21% have initiated their vaccine. And for our KP employee immunization rates, 75% of our health plan employees have been vaccinated, 94% of our physicians and hospitalists have been vaccinated, and 95% of our Permanente dental staff have been vaccinated. And now I will turn it over to Michelle Teeples. And Michelle has the title of Incident Commander for Vaccine Deployment, as she has been extremely involved in our vaccination rollout and our administration efforts. Sorry about that. Okay, Michelle.
Great. Well, thank you so much for allowing me just a few moments on your agenda today to catch you all up. I have a couple different topics, and I might go through them pretty quickly. I do think that you record your meetings, so for reflection, that's probably a good thing at the rate that I speak as fast as I do. So for the All for Oregon Convention Center, so I think it's important for everyone to know this has been a logistical masterpiece in partnership with OHSU, Providence, and Legacy. We have administered our 500,000th vaccine as of this morning, I believe. And we will be looking to close the vaccine center on the 19th. So prime doses will be administered through May 27th. And then only booster second dose shots will be administered at the Oregon Convention Center through the 19th of June. And it really is an amazing undertaking by many of our hospital systems within the Portland metro area. So, and I do want to call out that part of this closure is also allowing us to pivot as a health system back into smaller, more neighborhood and community-based settings. So just calling that out is this is not the end of vaccinating, just moving to more medium to small size so we can reach different pockets of folks. All right, so I'm going to take us to changes in masking guidelines. So albeit that there has been lots of conversation in the community around masking guidelines, we will continue to monitor those CDC guidelines and recommendations, but at this time our health systems are not impacted. So if you're coming into one of our facilities, you will still see people wearing masks and additional eye care if they're within, or eye coverage if they're within 6 feet. So nothing is changing in our medical office buildings or our hospitals at this time. And then as Sapari mentioned, we are vaccinating people 12 and older. So once we got the approval from the Food and Drug Administration and it carried all the way through to the ACIP, CDC, and all the governing bodies that have to sign off on it, we as KP, as well as many others on this call, have started implementing scheduling 12 to 15-year-olds in addition to all the other groups that are already eligible. So appointments for children 12 to 15 are now available and can be booked online at our kp.org. So if you have a kp.org account, you can pop in there. Our what we call our decision tree, so that space where you get asked a few questions before you get there, will not allow you to get the wrong vaccine. Only the Pfizer is eligible for this age group. So it will guide you to a facility that we're administering Pfizer and won't guide you incorrectly. If you are lucky enough to bring in your child age 12 to 14, in the state of Oregon, you will need a consent form signed and you will need to be present, either parent or guardian. In the state of Washington, the same consent form and guardian being present is required, but the age difference is it needs to be done for 12 to 17. And again, in Oregon, it's 12 to 14. So just a few nuances as you kind of step through the door with your adolescent for their vaccine. All right, so vaccine hesitancy. I think it's really important to call out that this has become more prevalent as the waning for the vaccine has significantly, we've significantly decreased the demand for it. Supply is not feeling quite as much of an issue as it is getting folks to come through the door. So our communications team at KP did some public confidence campaigns for those who are hesitant in our communities of color. So we did a partnership with KP, OHSU, and Legacy, and we did some 60-second social media public service announcements. And we shared it with over 700, I believe, organizations, public-facing organizations inside of Oregon, different agencies. And we had providers of color. We had providers who spoke Russian. So we had a kind of a mix of that, the different diversities that we're seeing where there could be some hesitation in some of those groups. So the public service announcements you can catch on our Instagram or online. They're really, really good. We also, inside of KP, have done a lot of population segmentation. So we're looking for those high-risk patients, either due to communities of color or age and comorbidities. We have a group of physicians that are doing some report pulling and some outbound calls, but we're also doing texting and emailing. So we're really trying to target specific populations to encourage them to come in. Now, I want to say, in addition to targeting these groups, we do, when you come in for, let's say you're coming in for a regular primary care visit, we do treat this as a care gap. So it will trigger an alert on the chart if they're eligible to initiate a conversation with the patient as well. And if we're doing vaccines in that clinic, we will escort them down to the vaccine space when their appointment is done. And then just a few more talking points, and then I'll hand back over to Sapari. We are and have been targeting our homebound membership population, and their caregivers. So we found some hesitancy in that space. So the COVID outreach team is also working hard to help answer any questions they have to reduce anxiety and stress. And then we also, as I mentioned, are trying to integrate this into regular everyday operations. So any chance that we can grab a hold of somebody who's eligible in the clinic, we will make it as easy as grabbing their prescription to send them on down to our vaccine teams. All right, so vaccine equity. So we did host 3 targeted events. So we did 2 Latinx events on May 1st and May 8th, and the results were amazing. So our vaccination rates increased 60% compared to, for our Latinx population, compared to our 45%, or I'm sorry, 40% of white members in all of KP membership. And then for our African-American population, or our Black members that are fully and partially vaccinated, this has increased over 45% when we did our targeted event for our African-American and Black community members as well. So, and then we did an Asian Pacific Islander event down in the Salem area, and they are now, that population inside of KP is trending at about 67% completed vaccination in comparison to our 62% of fully vaccinated white members. So you can see that we're trying to target and encourage vaccination efforts in those spaces and with those different groups. As we bring those groups through the door, we are also focused on social determinants of health. So we're asking them about food insecurities and housing insecurities. So we're really taking the opportunity to have this one-stop, take care of me while I'm here methodology, which is ideally that integrated care model that KP has. So we are doing lab draws, blood pressure checks. We actually found a patient who had stopped their meds the day before, and we were able to send them to, or the week before, we were able to send them to urgent care and get them the necessary care that they needed. We're talking about mammograms, diabetic eye screening. So we are really just trying to reinforce that one-stop culture inside of KP. And then, of course, the last thing we're doing around vaccine equity is that we've contracted with Medical Teams International. So this is a company that will go out into rural areas or employers that don't have the means to get their employees in, and will do vaccinations on the spot out in the field. So we're expecting about 50 van days, which is the equivalent of about 150 shots per van day out in the field. So Sapari, I'm going to go ahead and hand back to you to talk about benefits.
Great, thank you. I just wanted to provide a quick update on treatment costs. Our national benefit policy to waive member out-of-pocket costs for treatment related to positive COVID-19 diagnosis has been extended through July 31st. And so any positive COVID-19 hospital admission on or before July 31st will have a zero cost share regardless of the date of discharge. And so our standard cost sharing after July 31st will apply to our plan members benefit. So that's the update we have for you. I know we threw a lot of stats at you, so please let me know if you need some of this in writing, and we'll be more than happy to send it.
Thank you so much. All right, well, we're going to move on to MODA, and we have Dr. Robin Singh and Erica on, and then again, I'm sorry I am keeping you all to 10 minutes apiece, so that we can get through the updates. Thank you.
Good morning, Robin Singh, MODA Health. I'd like to provide a quick update on COVID-19. Globally, we have approximately 155 million cases and approximately 3 million deaths. Unfortunately, both cases and deaths are rising around the world, especially in South America, parts of Europe and the Middle East, Africa, India, amongst other countries. Many countries have little or no access to vaccines, and therefore a large number of cases and deaths are expected over the weeks and months ahead. Nationally, there are approximately 33 million cases and approximately 600,000 deaths. Only 48% of the population has received at least one dose, and this appears to be leveling off. Case numbers continue to decline across the country as vaccination rates increase. Recent hotspots include Washington, Oregon, Colorado, Texas, the Midwest, and Florida, though for the most part, most of these are seeing a significant downward trend as a result of vaccines. In Oregon, approximately 200,000 cases, and there have been approximately 2,500 deaths to date. Around 51% of the population has received at least one dose, slightly ahead of the national numbers, though this also appears to be leveling off. We're finally coming off the fourth wave with around 300 cases a day, although deaths remain in the double digits on some days, a little above 10 in some days. For Oregon, most counties remain at high risk, though none are at extreme risk anymore, and precautions should therefore continue. Looking at the breakdown for our PEBB members based upon claims data. Tests, the distinct member test count was 4,799. 7,167 tests were undertaken in total. Distinct number of COVID antibody testing was 331, with a total number of tests being 340. Cases, members with a COVID diagnosis, 390. Members with an ER visit was 54. Those hospitalized, 18. ITU, 8. And fatalities, 1. Vaccination numbers for Pfizer, those with at least one dose, 2,368. Members with both doses, 1,359. For Moderna, the numbers are one dose at least 1,468. Members with both doses, 750. And for Johnson & Johnson, just 181. Members received Johnson & Johnson. The costs for testing, $704,153. Treatment costs, $1,024,000, and total vaccination costs $254,108, and that's on a 17,537 total membership. There's likely underreporting on some of those numbers for reasons previously discussed. The biggest concern currently is that vaccination rates are slowing down due to vaccine hesitance, as we just heard. Furthermore, there is concern about the equitable access to vaccines, with many minority groups having lower rates of vaccinations, putting them at greater risk of harm. Variants. Another major threat is new variants, the most common of which are the B117, United Kingdom, B1351, South Africa, P1, Brazil, B1427, from first discovered in California, B1429, and from India, B16172. Took out the dots for ease of pronouncing that and speed. Almost all of these have reached Oregon. This is a dynamic and rapidly changing picture, with significant changes occurring within short periods of time in terms of which variants are of concern and of interest. To date, most sources suggest all variants are responsive to some extent to existing vaccines, though with newer variants, the efficacy of vaccines is reduced. Vaccine manufacturers are therefore working on a follow-up dose. The original goal was to reduce death rates by reaching herd immunity, thereby protecting those who do not have access to vaccines or are not able to receive them. At this stage, there are concerns that we may not reach herd immunity. However, we are still seeing a significant reduction in incidence and prevalence prior to reaching this theoretical target. If we do not, however, focus on providing vaccinations more widely, nationally and globally, there is a likelihood of new strains emerging and entering the US or spreading across the US, causing additional waves and prolonging the pandemic. Thank you.
Erica, did you have anything to add?
Thanks. I do not have anything to add. Dr. Singh provided a very comprehensive update for us today. So thank you, Dr. Singh.
Thank you both so very much. Okay, we're on to Providence, and it looks like I've got Greg and maybe Helen is joining us from pharmacy.
Yes, hi, this is Helen speaking, and I think Greg is on the line as well.
Welcome.
Yes, I am on. I can get us started. I've got a few updates on some stats and efforts on the care management front, and I will turn it then over to Helen to provide a pretty extensive review of all the work happening on the vaccination front. For the PEBB membership, we've had to date a total of 62 total cases in the inpatient setting. We have currently 2 active cases. We've had 29,324 members tested. Those are unique member tests, and 1,748 have been diagnosed. Our current positivity rate is running on par with the state to date. As far as the care management work goes, we have continued to focus and have been focused on those members most at risk. Much of that work is centered around those with comorbidities and helping them through managing their care, particularly with social determinants and overcoming any barriers that the social determinants may provide. In addition to that, we've been providing extensive education around vaccines and support with getting members coordinated with vaccine clinics. Helen's going to touch more on that vaccination effort as well. On the COVID front, we have also put in a focused COVID recovery or long COVID care management support program. This team is working closely to coordinate care with medical specialties, physical therapy, occupational and speech therapy, nutrition support, behavioral health support, as well as support with medication, reconciliation, and or education. And these, the care management team is working closely with the providers to help to coordinate a single care plan. And that's both with our PMG providers as well as others within the community. And I'll turn it over to Helen. I know Helen's got quite a bit of information to cover on the vaccination work.
Okay, hi, good morning. It's Helen Noonan Harnsberger. I'm the pharmacy leader at Providence. Good to be with you all again. I do have my my comments in writing that I've provided to Cash, and she can forward it on to Ollie and the group. But I'm just going to go through the facts of our basically COVID-19 vaccine deployment project, which we've undertaken at Providence Health Plan with a lot of coordination with Providence St. Joseph Health, of course, and the All for Oregon campaign. So to start with, we did basically initiate a 25 plus internal PHP caregiver member support team that basically was cross-functional to with a goal of facilitating, coordinating, and navigating COVID-19 vaccination for all PHP members, inclusive, of course, of the PEBB membership. And we wanted to do that in collaboration with our local health system, with Oregon Health Authority and the local public health departments, as well as our provider partners. As of today, 43,447 members have received a partial or complete vaccination for COVID-19. Of total membership, that represents 47.2%. I don't know about others. I'm getting a fair amount of feedback. I just want to maybe go, if you were on, you could go on mute. Thank you. Anyway, excuse me, that was 47.2% of all PEBB members, which if you adjust for age appropriate at greater than age 12 is 55.1%. So that's within PEBB choice and PEBB statewide. To date, of all members, 36.5%, so that's of every person, all ages, 36.5% have a complete series vaccination, which is 33,538. Looking at the age distribution by age band, your 65 to 79-year-olds in the population, a smaller number, but 80.3% of those individuals are vaccinated. And in the 80 plus category, where you also have some individuals, 75.5% are vaccinated. From there, it goes down 41 to 64 is 67%. Age 18 to 40 is 49%. 16 and 17-year-olds is 38.1%. And in the less than 15, 12 to 15, it's a really small percent. I found less than 10 members, but this data is up to date through yesterday. And of course, we just started vaccinating that age band on the 13th. The source of our data is actually claims data coming from a variety of sources, including the alert, which we get frequent updates on, as well as a number of other curated sources that we are able to work with to get all of this information together. Includes pharmacy and claims, as well as medical claims. Looking at one of our areas of focus is really looking at vaccination by race, ethnicity, cultural group, communities of specific belief systems. So as you know, acceptance of vaccination and other healthcare services is really related to the community to which you associate and to which you culturally or by race or other inclusive kind of situation belong to, including zip code, as we find that some of the most rural zip codes are particularly barren in terms of COVID vaccination. But we are focused on race and ethnicity. We partnered with Providence St. Joseph Health in a number of clinics that we had throughout the Tri-County area and Yamhill County. And then our care management did outreach and scheduled people for clinics in the Salem area. So there's been a variety of efforts. Looking at the distribution by race, there is still disparity within the PEBB population. 71% of Asians are vaccinated, 55% or 56% of white individuals, 53% of, or almost 54% of Black, Hispanic at 52.5. We have a category called unknown at 51.4, Native and Pacific Islander at 49.1, and American Indian or Alaska Native at 45.5. Those are people that have all received at least one dose. So the gaps are certainly have been closed pretty significantly over the last few days. I've been and weeks. I've been watching this area because it's been an area of focus. You know, we've really got have a number of communication efforts. We've updated our website 15 times with new and improved information as things have emerged, and we've moved from scarcity of vaccine to really a time of vaccine hesitancy. We have used postcards and email and social media for communicating to our non-vaccinators. At this point, we're focusing on that population. And as Greg mentioned, we are working with care management and our medication therapy management program to really prioritize those non-vaccinated high-risk individuals and populations. So we're basically going through our population and stratifying it based on various risk factors, including diagnoses. We have our inbound call centers at the health plan inquiring about COVID vaccination status or if they need information and offering to schedule. We're able to schedule right at the plan for people who still need a little help with that. And then we have been doing a significant number of employer group vaccination clinics. And early on, I know I reached out through Cash to Ollie, and I did speak with someone at OHA, Gilbert Galis, about doing clinics for PEBB. It was too soon because of the scarcity of vaccine. Now in the last 2 to 3 weeks that vaccine is more available, certainly throughout any parts of Oregon that PEBB would like to set up clinics. We do have participating pharmacy providers who can do clinics of upwards of 1,000 a day, and we've been very successful with that. And then as we work with people with hesitancy, we're really working to meet them where they are at and helping to answer their questions and to nudge people along in that decision to get vaccinated. We have worked a lot with both our caregivers and our providers to really know where to find vaccine based on the individual member need and the community need. So we have projects that we have worked on to identify our homebound patients. They've been referred by care management and or to their local county through a coordinated process to get vaccinated. And I know in the Tri-County area, we are almost through our list of, I know the total homebound was 1,000 plus, and we have nearly gotten through that population, which did include PEBB members. And I've mentioned work with the communities of color and our participating pharmacies. But in addition, with PMG, we've worked with them on their drive-through clinics, and of course at the Oregon Convention Center. But I think one of the things that I most, one of the areas of learning for myself was just really the great, really public health partners that we have in our rural communities, that outreach to those public health entities and partners really around the state has been really helpful. It has helped us find vaccine for many individuals as well as groups of people to get clinics set up in particularly those high-risk areas. And then now we're emerging to really focus on the shift from mass sites of vaccination or large sites to even smaller community sites, and really more direct involvement of PCPs. As many know, at least through most of the Tri-County area and Yamhill County, physicians, PCPs, and direct care providers did not have access to vaccine. And now over time, across the state, many of the PCPs are getting access to COVID vaccine, working through the logistics, which the logistics are true and real. You know, the production it takes to really give vaccine, and the potential for waste has been significant. OHA has eased up some of the communications around don't waste anything, because in these rural communities, there does have to be some waste, because you can't find 10 people to to vaccinate, and Moderna is a 10-dose vial, for example. So we're working on that, working with the physicians through information and assessing which ones are going to be giving vaccine, and then focusing on smaller clinics that we can offer in communities where we have groups of non-vaccinators. So I think Cash reached out to Ollie either late last week to really talk to PEBB about if there are some locations around the state that you would like to have vaccination clinics for your population. We're ready to work with you on that. There's enough vaccine. We can probably spin those up pretty quickly if we just need to make a schedule, basically. And so with that, I'll just open it to questions.
Perfect. Thank you so much, Helen. Does anybody have any questions for any of the three before we move on to the minutes? Thank you very much. All right. I believe Jeremy has joined us. Jeremy Vandehey. Maybe on mute.
Yeah, I think Jeremy was on the phone.
Okay,
Kimberly.
so what digit does he end with? Because I muted some of, we had a lot of back feed.
Oh, okay.
What is the last two digits of Jeremy's? Do we know?
I will find out.
I'm sorry. So, and then Mark Perlman, were you able to join? Guess I can unmute these phones, but we just had too much feedback coming out of people's. Oh. Okay. So we have the
Kimberly, this is Ollie. We did have Kate Nass join as well, so I think we do have a quorum. Yeah.
Oh, wonderful. All right.
Kim, I just unmuted myself to say I'm here. I'm sorry I was late.
Thank you so much. Okay, so we had the minutes that were presented for the April 20th board meeting. Do we have a motion to accept these minutes as written?
Kimberly, this is Kate. I'll take a second. I'll do a second for you.
Okay.
I don't know if I needed to be on during the motion or not, but.
So I need a first. Do I have a motion? Oh. I'm sorry, I'm not hearing everything.
Sorry, this is Siobhan. I'll make a motion that we accept the minutes as written.
Thank you. And then Kate, second. All board members in favor?
Aye.
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 Maybe I should do roll call. I'm sorry. Okay, so Kate was the second. Dana's excused. Kim?
Aye, yes.
Thank you. Sean, I think I heard you.
Yes.
And then was Mark able to join us? Okay, and then Saban was the first. Jeremy? Okay. And then Dana, sorry, Kate. Yeah, okay. I think I got you. Any question or any opposed to accepting the minutes as written? Okay, so before we start, I just want to say that today we're going to see the final rates of the 2022 plan year, which will be up for the board's approval. Typically, this is done in our June board meeting, but we're a month ahead. And so if the board does approve these rates today, we will give the board the month of June off. With that said, Ali would like to have a discussion with the board at the end of this meeting to discuss the possibility of PEBB offering a vaccine incentive to members. And this will require just an impromptu short board meeting, about 15-20 minutes in late May or early June. If that sounds okay, we will see how today's meeting goes, and then we might not have a meeting in June. So with that, I'm going to go ahead and kick off. So our next presenter is Cascade Center's EAP update, and we're going to have Julie Marshall is going to join us. And thank you, Julie. And I'm just a couple minutes behind, but welcome. And I'm just glad that we were able to get you on the agenda and you're here today. Thank you.
Yes, thank you. Good morning. Now, should I go ahead and share my screen? I see you have a slide up there. And go through.
Julie, you can go ahead and share. You can share your screen. I'll get off.
Okay. So now, do you see that same mountainside? Do you see my screen?
Yes.
Okay. So, all right. So good morning, everybody. I will try to stay on time and get through the slides. Certainly stop me if you have any questions and let me know kind of what more information you would like as we go through this. And so just the first slide, I'm not going to go into detail on this slide. I think you all are fairly familiar with the EAP services. I did want to put them up there in case there are some specific questions. Some of them I'll be going through in more detail later on. The main point, I think, of this slide, every year we add several new services depending on, member demand and kind of what's going on in the world and what services are relevant. And so that's always growing. And in concert with that is the way we deliver those services, which I'll talk a little bit more, but it's real important for us to continually be innovative in how we're delivering those services, because no matter how many services you have, you need to make sure they're accessible. So that's the main piece in terms of our service development model. But please let me know if there's specific services. I also did include and got you a copy of my bigger report that summarizes things in more detail, as well as the utilization report, so that could give you another level of detail there as well. So as we all know, 2020, and really I should add 2021 onto the date stamp there, was a year of significant events, right? COVID is still looming for us as we move through that, but there were the fires and the racial justice and this, that unrest that happened there, and the political unrest. So it was a string of events that as the EAP, we definitely were responding to, both on the member level and the organizational level, so at the agency level as well. And so I'm going to talk a little bit more about that. I've told you some things around COVID, so I'm not going to spend a lot of time here unless there's some questions, but certainly increased services was one of them. Prior to COVID, I think 5 to 8% of our services were given through our counseling services, were given through telehealth, and that was with us really pushing to try to get people to use that as another modality. And of course, once the lockdown happened, that increased dramatically to mostly 100%. And so there was a shift there that we needed to do. We were able to do that without disrupting service. And throughout, since the COVID quarantine, the pandemic has hit, we've created hundreds of customized promotional materials, 75 just specific to COVID, and it's evolved in terms of that education and that outreach that was needed, whether it was first talking about how to deal with social isolation and how to cope with that, now coping with vaccine anxiety and working remotely. And we've done a lot of series and support for leaders and managers, and then also highlighting EAP services and really working to try to get people to access those services that might be most relevant that they hadn't thought of before, financial and housing support and resource retrieval, and of course, emotional support, which has been paramount. And one of the things too that did develop was that increase in more that group support. So we had a big increase in hearing from people at the agency level, at the HR level versus just the member level, and asking for support for groups of employees. And traditionally that support has been, whether that's scheduled educational seminars, but if it's a group debriefing, it's been a one-time stressor that's occurred, like a death of an employee. Well, that's been different this year. It's ongoing stressors that have been going on for people, and how do we support them, and employers asking for kind of different ways to support them in that group format. And so we've been doing a lot of those and a lot of different tailored webinars, and some specifically for PEBB members. They are always, whether it's for PEBB members only, which is why we did that, because they were getting so full even in our general webinars, and we give 2 or 3 specific topic seminars a month on those. And so those have been something that people seem to have been really wanting to access and wanting information in that way. The same with equity and inclusion. DEI has been very important. It was important before the events that were going on in 2020 and continue, our provider panel diversity and having that representation, but we did an increased focus on that and have increased that diversity, and not only in adding additional providers that are BIPOC or from the LGBTQ plus community, but also in our search capabilities and the ability to match people with the either BIPOC or LGBT community that they are wanting, that feels is a best match for them. We added racial trauma as a clinical specialty and worked closely with our providers, so we identified who had that specialty so we could get people connected. And just like with COVID, a great deal of educational flyers and those customized webinars and process debriefing groups. There were quite a lot. Members, agencies at the agency level, because of all the unrest and how it was affecting a lot of people, we got a lot of requests on process groups where people could come in and get some coping skills and talk about how they're dealing with these ongoing stressors related to that. So moving to more overall utilization of the EAP, and again, you do have a more detailed utilization report. PEBB this year overall, this is 2020, was at 8%. And that is a drop from last year at 9%. And while our overall book stayed about 8%, there was across the board a dramatic decrease initially once quarantine and the shutdown happened to people accessing face-to-face services. I think people were distracted. If they were coming in and wanting to access for marital or stress, those things went to the wayside when that quarantine first hit, and they weren't calling us for those things. Now, the calls we were getting were much higher in acuity. So we were getting more calls, higher percentage of calls of people in distress and wanting that in the moment support. But in terms of that day-to-day counseling, that did dip. We are now back up to previous levels. So there was a dip that happened over 3, maybe to 4 months, and now it has gone back up. So I anticipate that utilization is going to be back up to the previous level, if not higher than last year. And if you look at the top 10 presenting concerns, again, you can see all the presenting concerns on the utilization report. This is pretty typical, both for PEBB and across all our employers, these kind of sometimes shift positions at times. Legal is typically the #1 issue, and domestic separation is the #1 legal issue. So really marriage relationships dominates the first two pieces. You'll see a new one, this COVID concern related. So that's definitely, and not a surprise that that's in the top 10. When COVID first hit, we weren't measuring that. We were just looking at things as typical presenting issues, anxiety, stress management. Then as things stretched, we really felt it was important to also reflect how many of these issues were COVID related. So then if someone's, as they were talking to a counselor on the phone, if they were expressing anxiety and that anxiety came out of COVID, we would mark that as a COVID concern related. So we were able to start tracking that. And so not surprising, that shows up in that top 10. Looking at sessions used by case. So for all agencies, it's pretty split between, so they have 3 visits or 5 visits. The agency chooses which session model they would like. All other benefits are the same other than how many counseling sessions they receive. And so 54% of all agencies have that 3 visit and 46% have the 5 visit model. So almost pretty evenly split, but many of the larger agencies do have that 3 visit model. So if you cut it by members, 65% of all PEBB members have a 3 visit model and 35% have a 5 visit model. And that's reflected here. So of all cases, you know, this is the amount that used 1 session. This is the amount of cases that used 2 and 3 and going forward. So you can see, obviously, there are more people who have a 3 visit model. It's the most used, but also the 5 is the second. So people are using their sessions, and this is just another way to give you a snapshot of that. Agencies also request this snapshot. We can do it by agency to show them kind of where they are. Many times the 5 visits, when they're looking to renew, the 5 visit agencies want to see if their members are using those 5 visits, and so this is a good way for them to be able to see that. We also look at case disposition. So this is a measure that is done at the end, the conclusion of the EAP visits. The provider reports this to us, the counselor. So 84% in the end attend their EAP sessions only. So it may be that they just use 1 visit, you know, as you saw on that last screen, or they used all 3 or 5 visits, but that they only use their EAP sessions. 13% continued on with the EAP counselor. So at the end of their EAP sessions, they continued on for additional sessions. Typically that is continuing on with their insurance. And that's something that we make sure that we do whenever possible, is match a member up with an EAP counselor who is also on their provider panel. And then 2% were referred to other resources. So that may be things in addition to counseling, maybe some community support groups, or maybe there is some medication management they need and helping refer them to a prescriber. So something that's outside of EAP, but not the counseling, continuing on with the counselor. Care navigation is, and it always has been, kind of a keystone of our counseling services that we provide. And, you know, with the provider shortage that's gone on, you know, and gotten worse over the last 2 years or so, which COVID made that even worse in terms of counselor availability. It's become really important for us even more to be following these cases very closely, because people are calling us at a moment in time, and sometimes that's not so easy, or they can access us online as well. And so we want to make sure that we are able to get rid of any barriers that might come in between when they call us and when that appointment happens with their counselor. So we do enhanced follow-up. What happens is a member calls us, talks to a counselor about what that issue is, what service they want, and we match them up based on that criteria we get from them with a counselor that's the best fit for them. And then that's the last call the member makes. We call that provider, give them the information, and have them call the member to set up an appointment that works with their schedule. And but our follow-up doesn't stop there. The provider calls us back when that first appointment is set, And if we don't hear from that provider within 24 hours, we start the follow-up. And we work with the provider and the member to make sure that first appointment is scheduled. And that's real important for us. The time starts ticking at that point because we want to get them in as soon as possible. And if there's any barriers, such as maybe the provider wasn't a good match, maybe their schedules didn't match up as they thought they would, things like that, we don't want that to be the dead end for the member. So if those things happen, we can quickly reduce whatever that barrier is and get them in. And we know it's working. We are below the industry standard. We're quicker than the industry standard in getting people in. So from the point they call us to their first appointment is an average of 6.3 business days for PEBB members. That's PEBB specific data. So we know that getting in quickly and reducing those barriers is getting people in a timely manner. And that continuity of care is very important. So I mentioned earlier, matching people up with their insurance in case they need to continue on. And that's a real important piece. We've also added on following up with them after that first appointment as well as a second touch point to make sure that things are still going smoothly and they don't have any questions, even offering if they needed to, and make sure they knew that they can even change providers if they need to. So again, wanting to make sure that those barriers are reduced and they're getting the help they need. And we do follow up 90 days after their first appointment. And do a touch point, and they opt into that, and we ask them permission for that to follow up to make sure that they don't have any questions or there's nothing else that's going on. And they also get our client satisfaction survey, which is a good segue into this slide. This is the satisfaction survey data. It's also summarized in that report that I included. So you'll see over 95% rated their overall satisfaction with Cascade, that they were satisfied with their services. Almost 98% stated that the EAP staff, Cascade, treated them courteously and professionally over the phone. And this is a number we watch 93% rated satisfaction with the speed to which they received an appointment, because that's an important metric. We want to make sure people are getting in a timely manner. And it takes more and more time for us to make sure that that's what's happening. You know, as I mentioned, we're doing a lot of work, even more this year than normal at the agency level, not just at the member level. These are a couple promotional materials we put together for DOC, Department of Corrections. So we've been working with their group really closely this last year around how to really make this benefit more well-known, more accessible, more people using it. One of the things was developing some new promotional materials, and they're working with us on the images we use, the testimonials from members. You'll see we even have branding for our public safety. This is not just for DOC, but other public safety. This is a group that really wants to know that we can serve them and have the providers who specialize in working with them and know about them. And so that signifies to them that we really tailor things. So we have a lot of different tailored materials that we do for them and other groups. We do a lot of consultation on utilization reporting and specialized promotion that agencies can do within their agencies depending on their report. We meet with HR groups within agencies and across agencies, the wellness coordinators, and this last year more than ever, working with ERC groups on DEI issues and doing both promotion of the EAP and also subject matter trainings, which is what the group response is to. As I mentioned, we've been getting a lot of requests that are different from a normal webinar, but that is more interactive and more specific to all these current events that have been going on. So what some of the things we've been doing that have been requests from agencies, doing a live webinar on a specific topic, and then opening it up afterwards for a group process session so people can ask that counselor who did the training specific questions, things like that. But we've done mini webinars where you do half hour of content and then the agency decided to then provide one-on-one virtual sessions that a person could schedule as a way to lead into that. And so we've been doing a lot of different types of groups. The critical incident response is not just one point in time. Sometimes it's been several sessions depending on the group and what the situation has been going on. So there's been a lot of things that are tailored within that group. Each agency is been responding differently is made up differently. And so we work with them independently around how to best serve the population. Then finally, I just wanted to give you an update on the whole life directions. You know, as you know, we started that July 2020, and you know, the timing really couldn't have been better in terms of really providing a service that is accessible, it's confidential, and it's another way for people to get that support, an interactive, engaging way that's just right at their fingertips. And so we started in July and August about doing an overall promotion to raise awareness about whole life directions and education on mental health, and encouraging them to take the whole life scale. You know, PEBB, you provided the incentive as to engage as 2 HEM activities. So there was a lot of promotion around that. We did home mailers, we did videos, website, we met with different groups. The agency wellness coordinators were very helpful, HR managers. So we really did disseminate that information across the PEBB population. And so you can see this is just where it started. It went up. We had a total of 2,023 registered members. 90% of those who registered and started the app and went through that process completed the whole life scale. So a really high adoption. It wasn't just that people got online and looked at it. They got online and took that assessment to get started with the program. And so we worked with PEBB staff. After about 2 months of collecting data, the whole life directions is still open and we still encourage people to take it, but we chose a snapshot in time to really guide us around, you know, where should we focus then for the remainder of the year in terms of where's the highest stress. And so the 3 highest were anxiety, depression, and sleep. And so we focused on anxiety, which was very appropriate given where everybody was around that time and with COVID, and specialized materials around anxiety with COVID, and directing people back towards the whole life scale and the services we have, and also provided education. And so we did webinars and email campaigns around all of these. We're finishing up. We're just getting started on sleep, and then we'll finish that up. And then our next piece will be, as we renew with it in July, working on encouraging those users who have used it to do a reassessment and what that means and how they can select more goals and work towards that, and maybe continue the goals they have done, as well as looking at, for the population as a whole, what things we might want to focus on. And so there's the organizational interventions we've done that I've talked about in terms of the webinars and the intervention and the educational campaigns, but all through this, individuals are also being engaged through the program itself. Obviously the assessment and the recommendations and the interactive tools afterwards, but they opt into this, but then they receive push notifications asking them to come back if maybe they didn't finish a program or they paused for a little bit, and educational emails tailored to their results and information that they might be interested in or might be most relevant to them. So just real quickly, some of the new services, I'm just going to highlight some of the bigger ones for this last year into this year. Starting now, this just got released about a month ago. We have an updated utilization report, so it looks very different than the one that I submitted to you from the 2020. And it's a much easier to read format. It includes more data in terms of our member site, giving you some of that data on the website. It also came with an updated login, so HR members and managers can log in to look at their agency utilization reports and not only run reports in the time period they would like, but also be able to have contract information in there in terms of the benefits and what's included. So they're able to do some of that just even on their own. We have a lot of agencies that call us and have us run them manually, which is fine. So they can still do that, but this allows them to do that whenever they would like. And fertility health, we just put this out in terms of a new benefit. And this is something that, because of demand, member demand, we've been hearing a lot of people who are wanting help with this. So they're not only able to get discounts on consultation and fertility health services, we help them find those services based on what their needs are and what the best fit would be. And we also have on our EAP member side a lot of content dealt with this topic, as well as specialized webinars and information on that. And the member site is has been updated. There's going to be some more work. Right now, it's really around the content is a lot the same. It's just optimizing that. You know, there's always so much content there, and it's around how can we help the member get to that information quickly. And one of the things that's going to happen by the end of this year is this will be completely redesigned and much more interactive in how it gets people to the resources online and being able to access us more directly online as well. And so there'll be more about that as the year unfolds. Whoops. And then before the end of the year, probably within about 3 months, members will be able to access telehealth and schedule themselves online without calling us. They can access that service right now, of course, but now that scheduling will be online. And by the end of the year, we're hoping that would be open up to both, well, as soon as face-to-face starts, but to whatever type of counseling they want, whether that's face-to-face, whether that's telehealth, whether it's life coaching, and being able to schedule that online without having to pick up a phone. So now that is the end of my presentation, and I'm trying to figure out how to stop sharing. Let's see.
Thank you, Julie.
You're welcome. Are there any questions?
Kimberly, this is Ollie. If I could just jump in and really express my gratitude to Cascade Centers and really our partners that you heard from earlier as well. I think over the last year, we've really run into some really unique situations, really unique crisis situations that Cascade really stepped up and fulfilled a void for several different agencies, which I was really grateful for. And I know, as we saw with OEB, that utilization did decrease over the last year, which is kind of surprising. But at the same time, as Julie said, it was really the acute situations that our EAPs were so valuable in. So thank you.
You're welcome.
Great partnership.
Julie, I had a couple questions.
Yeah.
First, so people can still sign up for the whole directions?
Yes, they can.
Okay. How do they, how would a member sign up? Like, how do you come across it?
Well, in terms of how they come across it, right? So we've been promoting it in a lot of different ways through the website. So they can log on, they can sign up online, or they can download the app. Is that what you're asking? So they can download the app and register there, or they also can register online.
Okay.
So the app asks you for an access code.
Right. It's and they can put in, and that's where we've been trying to let people know it's PEBB or State of Oregon.
Oh,
okay. Because I just Googled PEBB whole directions, and it went to a whole directions website, but it wasn't specific to us, like there was no sign in. So like what website, how would they, like, what would you Google to get you to the right spot? Like, you know what I mean?
Yeah, to Google. I think there's a link on the PEBB. I can just look it up real quick on the PEBB board site. I could send you.
Yeah, so I was
spend me time Googling, but I think on the PEBB board or on the PEBB benefit site, there's
I was
link.
looking there too. I didn't see a link.
Okay.
Sean, did you see the wellness page that has all the links to our different wellness?
Yeah, I didn't see that either. I mean, I see the Cascade Center. Is it
Okay.
underneath there?
Okay.
But there's not like a link to like.
The best way, what we do try to get members to do is to just go ahead and go to their phone and download the app. So most of the promotion is around, because that's the best way. That's where they can use the self-use programs the best. That's where they're going to get their notifications and information and engagement and things like that. And so a lot of it, and that may be, I'm trying to talking to you, but that's where a lot of the promotion is pushing people to, and it's Android or iPhone, and they download the app.
Okay.
Yeah.
All right. That makes sense. So,
Okay.
My other question was the slide about so, I don't know, agency level customization.
Mhm.
And you mentioned some live sessions with someone that then people could follow up with that person.
Mhm. Mhm.
How are there people that you're able to find that are kind of specific? They have a background that is specific to that agency. For example, firefighters or corrections or state police, something like that. Like there's a person that has some experience with those kinds of groups. Yeah.
Yeah, definitely. In those, like those specific examples, it's providers who have experience working with those particular groups, and so our counselors do. The other request, similar to what you're saying, is in terms of some of the DEI trainings. We've had specific requests for people of color, and so then we use our full panel and to meet those needs as well. Yeah.
Thanks.
Mm-hmm.
Thank you, Julie.
You're welcome. And if there's any other questions, I mean, certainly let me know. Ollie always knows he can just email me. So, but anything else you need, just let me know.
Perfect. Thank you so much. All right, looks like we're ready for Nick and Mitch Mercer for final plan design.
Yep. Sorry about that. I was clicking mute, unclicking mute, and muting myself multiple times. So here I am, and I believe Mitch is on as well. So let me get into this, and we can get going. So good morning, everyone. As Kimberly mentioned, we are a little bit ahead of schedule for this year, which is not a bad place to be in. We have made all of our final decisions as of last board meeting. So what we have for you today is final approval of the rates. We also have a discussion on the composite rate, where that's coming in at, and then whether or not the board would like to do a funding assessment. For those of you that read the material in advance, the funding assessment, if you choose to implement one, would be much smaller than some of the funding assessments we've had in the past. So with that, I think we can dive right in. All right, so guiding principles, unchanged. Again, just giving us a frame of reference for the decisions we already made in the previous board meetings. And then for the health equity strategic pillars, again, another set of guiding principles that we have for those items as well. I will turn it over to Mitch to provide a recap of the prior board meeting and our renewal season.
Yeah, so kind of just taking a look back. So in March, the board approved to cover treatment for COVID-19 until the end of the pandemic, aligning with all PEBB plans. And then in April, the board then approved the 35 annual max for fertility treatment, and then to include coverage for artificial insemination, and then no member cost share. And then looking to last month in May, there are a couple more follow-ups on fertility, allowing in and out of network providers, accepting, and then all the rest, accepting MODA and Providence recommended plan changes, MODA 360 enhancements, and proposed alternative benefits to align with the essential health benefits for alternative care. Accept MODA's proposal for storage COEs for facial feminization and the vision therapy on VSP. Nick will kind of go into a little bit more detail on these and the costs associated with them later.
Any questions from the board on the final decisions either made last month or in prior months?
This is Siobhan. I just wanted to clarify on that 35,000 annual maximum. It's happening on the back end, what's split between pharmacy costs and the procedures, right?
Yeah, that's a great question, Siobhan. So we have some updates to share, and I guess I can do that now. So we've been in contact with all three of your carriers on figuring out how this benefit is going to be administered for 2022. Kaiser and Providence will have a separate bucket, and that will be split between $25,000 of medical, $10,000 of pharmacy. Moda feels confident that they can administer actually a single bucket. And so this is actually our preferred method for administering this plan, because I think it allows, again, more flexibility between the provider and member to split the bucket however the member needs to in order to receive the appropriate treatment. Just administratively, Kaiser and Providence aren't able to do the combined bucket at this time. We're still exploring that further with them. Just for 1/1/2022, it's not going to be ready in time for either of those carriers. But Moda is proceeding with the shared bucket for the 35,000.
Okay, thanks.
Yep. And just on the artificial insemination and IUI in particular, that was already a covered benefit, but we moved that to be covered within the $35,000 annual maximum. Again, we're trying to incentivize lower cost treatment options. If a member could use IUI or other forms of artificial insemination, and that would be clinically effective for that member, we wanted to provide that option at a no cost share to them. So we moved that from what it was, which was 50% coverage, into the $35,000 maximum, which is 100% coverage. Okay. All right. So composite rates and final decisions. So this slide outlines the composite rates. It's relatively unchanged from last board meeting. So if you recall, in last board meeting, we actually priced all of the plans to have all of the various recommended changes included in them, with the exception of Kaiser had the outstanding question that you all voted on regarding the alternative care benefit and what copay to apply to the new alternative care benefits. So relatively unchanged on this slide. So what we have here is essentially the final plan changes. So 2022 final plan changes. The composite is coming in at 3.3% above 2021 composite. And then what we have on the last row is the funding assessment. So whether to apply a funding assessment to bring it up to the full 3.4%. And in years past, we've explored the funding assessments in order to not miss out on the opportunity cost. Right, so we don't get credit for being under the 3.4% in future years. And so, to the extent that we fall below the 3.4% in each given year, it sometimes behooves us to get the composite up to that threshold. So we can work, we have a little bit more of a runway in future years as medical and pharmacy costs, likely trend higher than that 3.4%. You can see that we're, obviously so close to the 3.4% anyways, that funding assessment really only adds about $1.2 million or so of a buffer. It's still a buffer, but it's less so than, for instance, what we had in the 2020 plan year when we added, basically a 2.7% funding assessment. And then last year, we actually bought down the rates to that 0.8% increase with that negative 0.855% funding assessment. So that's where we stand. Are there any questions on this slide before we actually talk a little bit more about whether to apply the funding assessment? Okay. So this is the only decision that, well, actually, I shouldn't say the only decision because we do have to approve the rates later on, but this is the only outstanding decision that we have for the 2022 plan year on whether to apply the funding assessment or not. So it is a decision point, so we can either use the 0.117% funding assessment, or keep the rates at the 3.3% increase. So over on the left-hand side, bottom left, we do have a few background and considerations. As of the end of this plan year, we've alluded to it. I think Ollie has alluded to it a few times that the surplus is grown substantially over the course of 2020. We, after accounting for all of the incurred but not paid or incurred but not reported liabilities for each of the self-funded plans, the surplus is around $350 million. And it has been accumulating over the first 3 months of 2021 as well. Now we do have a transfer coming out, I believe a $63 million transfer coming out effective May or June of this year. So that is happening. But even after accounting for that, we're above the reserve target. So as of, when we last did the RBC, the risk-based capital reporting, our target was 191.9 million, which created a surplus then of about 150 or 160 million dollars or so by the end of 2020. So we do expect, as we're looking forward, right? So the big question is, when do the reserves fall under the threshold, right? Because as medical and pharmacy claims trend upwards, and we're capped essentially at the 3.4%. When do those fall below? In all likelihood, it doesn't happen until at least the 2023 plan year. So at the end of 2021, end of 2022, even without a funding assessment, we're likely still in the green as far as, the reserve being above where the target risk-based capital level would be. So we're still in good shape for at least the next couple plan years. And so that's sort of the update on where the reserve is and the risk-based capital. Again, the funding assessment does provide a little bit of a buffer this year at 1.2 million, but it's not as high as some of the prior years when the composite was coming in much lower than that. So any questions?
I don't have any questions. I just want to make a comment around this. I do think, we have to continue to be responsible as a board around how healthy the stabilization fund is. And when we're meeting the target, it feels like we should not continue to accumulate additional funds in the stabilization fund. And I know 1.2 million isn't a lot, but I don't think we should be accumulating that at this point, given where we are, because we're very healthy in the funds. So I would make a motion that we do not put money toward the stabilization fund and keep the rates at 3.3%.
And Siobhan, this is Kate. I will second that.
Is there questions or comments?
Slide 8.
Okay, I'm going to do a roll call on this motion. Ali, is that okay?
Yeah, definitely.
Okay, so we have a motion on the floor to not apply the additional 0.117% funding assessment to the composite and keep the composite rate at 3.3%. And so Kate is the second. Dana is still excused. Kim Harmon, do you support this motion? Sean Parkman?
Yes.
Mark Perlman, were you able to join us? Saban was the first. Jeremy Vandehey, were you able to join us?
I am here, and yes.
Okay.
Hi, can you hear me?
Yes. Who's this?
Okay, great. Sorry, I heard the second and then I went offline.
Oh, there's Kim. So the motion is to accept the 3.3%.
Yes.
And do you vote in favor? Thank you.
Yes,
Kim.
and I did hear the motion and I heard the second and then I went offline.
Okay,
So,
perfect.
yes, I vote yes.
Okay, any opposed? Looks like this motion carries. Did I get my math right, Ali?
Perfect. Thank you.
Okay. Okay, so next up, Nick.
All right, perfect. Thank you, everyone. So we did want to outline, so Mitch went over a high-level overview of what the plan design changes were that we all voted on, or that you all voted on over the past 3 months. We wanted to show sort of a visual representation and a essentially a cost impact for all of the various changes. The first one, the first couple are Providence related, then it's MOTA related, and then we have a few that applied to all the medical plans, and then we did make one change, obviously, in the vision plan. So on Providence, we do have the upcoming change effective June 1st to Cigna for their WRAP network. So again, any claims flowing outside of Providence's core service area here in Oregon and Southwest Washington will now be repriced and adjudicated through Cigna instead of First Health First Choice. And then for Providence's out-of-network services, so any claim going to an out-of-network provider, it is now going to be repriced essentially or administered by Clear Health is their out-of-network claims adjudication vendor. Overall, Providence made this change to save their clients quite a bit of money. So for PEBB, that impact is estimated to be about $8.4 million or so. That is on the conservative side. So we're hoping to actually reap additional savings from this benefit as the claims flow through. But just for underwriting purposes, we were a little bit conservative on what we thought it would, the impact would be from a prospective, rating standpoint. Also for Providence, we did accept all of the standard contract changes. So pain management, ABA therapy, the drug-induced alopecia coverage, and then Kaya Health, which is a new MSK solution. For MOTA, they are changing, and I think we have an OPDP update coming later in this board meeting. So we have an estimated pricing impact for PEBB that's estimated to save about $276,000 for this upcoming plan year, changing from Med Impact to Navitus as the PBM for that OPDP contract. And then we also have the various MOTA had a plethora of other changes, including some of those to MOTA 360 and to some of the core offering. All of those are worth $44,000 for the core offering, and then that $37,000 that you see here was doing the if you recall that 46-cent PEPM dental integration. So they're having MOTA 360 integrate with the medical plan, and for those members who are covered under both medical and dental on MOTA, they'll have an enhanced view of those members and be able to better address gaps in care for those members. And then finally, MOTA at the last board meeting did recommend that we use OHSU as a center of excellence for all facial feminization surgery. So to the extent that MOTA members are needing those procedures, they will direct the care to OHSU for the upcoming plan year and beyond. The big one that we talked about in March, obviously, was the fertility coverage. That was an estimated to be about $6.1 million or so. So I think it's no small feat that we are, collectively as PEBB and, the board are able to provide these benefits to your members and staying within the 3.4% composite rate. These are, rich benefits. And they are going to help a lot of people, and so it's no small feat that this was able to happen for this upcoming plan year. And I know we had to push it out 1 year due to COVID last year, but again, I think this is going to be a really great benefit for membership. And then on the alternative care benefits, again, the changes to the essential health benefits for this upcoming plan year by Oregon statute. So we now have to remove the cap, the $1,000 cap that was in place, and change to a visit limit. So we've done that. And then for Kaiser, as part of that change, they actually improved the benefit for naturopaths. So naturopaths were originally under that alternative care benefit, and it was a $10 copay to see a naturopath. Effective 1/1/2022, Kaiser is moving naturopaths to a regular office visit copay, which is $5. So that's actually an improved benefit for folks who use the naturopath services. And then the last two on the WPATH alignment. So for the facial feminization surgery, we did estimate a slight cost impact of about 0.5% on the self-funded plans. Kaiser priced that in without a premium impact. And then finally, for the vision therapy coverage, we did add that to the VSP plan, and those are the services that are not covered. It's a weird gap, right? Not covered on the medical, also not typically covered on vision plans, and so we addressed sort of a gap in care and expanded the benefits for folks who need eye training and other therapy services for their eyes. Okay, Mitch.
Yeah, so this next slide is kind of an update on performance guarantees. So kind of with the IWG, Mercer and staff, so Margaret and Ruby, have been working with the carriers to kind of update the performance guarantees. So performance guarantees are just a set of metrics that both the contractor and PEBB would agree on to basically hit to make sure that they're hitting certain targets. So kind of up at the top, the administrative, operational, financial trends, and clinical quality. So all three medical carriers, Providence, Kaiser, and MODA, have agreed to put 15% of fees at risk. So for MODA and Providence, your self-funded carriers, these will be your administrative fees. And then Kaiser, this will be part of their retention fee, which is essentially an administrative fee baked into their underwriting. And so again, all three carriers will put 5% at risk for each category. And then we kind of have these other categories at the bottom, clinical management, account management, and transparency. We'll still be measuring these, but they'll only be on a report-only basis. And so it's kind of in conjunction on how it is today. So just an update. So we've been working together with the carriers to kind of come up with set metrics for each of the three categories or each of the 6 categories. And so we've taken their feedback and we've kind of proposed alternatives. So right now we're just kind of working through setting those metrics for 2022.
Any questions on the performance guarantees? Okay. We are excited to get these sort of developed for both PEBB and OEB for that matter. I think this is good work that staff and the carriers have been putting in to get these further refined. All right, so are we ready to approve some rates? I see Kimberly's face. She is ready. So I don't know, Kimberly, how we'd like to proceed, whether we want to go through all of the, and I think I ask this every single year, but do we want to go through all the rates and then approve at the end, or do we want to go slide by slide and do the approvals?
So I think we can look for a motion for all medical rates, and then we can look for a motion for dental and vision, I think is how we can break that up. And we don't have any other rates to vote on, right? For any of the other benefits?
Yeah, those all remain the same, the status quo for everything else. Yep.
Yeah. So I think we could do it that way.
Okay. All right. Oh, go ahead. Sorry.
Oh, so you want a motion, Kimberly, that we proceed that way?
Well, I think he's going to present, right? Are you going to?
And then we'll vote that way. Okay.
In front of me. I didn't print it.
But yeah, I'll go through them. Shaban is also ready to get these approved. All right. So we will start with Kaiser. So these are the fully insured medical rates. On the top, we have the full-time HMO rates. On the bottom, we have the full-time HMO for the non-HEM rates. And so Kaiser again went a slight increase for this upcoming year. All of the rates shown here are prior to the PEB admin fee, the consultant commission, and the funding assessment. Obviously, for this year, we just voted to not have a funding assessment, so that wouldn't apply anyways. But they also do include the 2% premium tax. For 2022, just a reminder, the PEB admin fee is increasing slightly. It's going from 0.7 to 0.75%. And then the consultant commissions are going from 0.2% to 0.4%. And that's based on a few of the projects the board approved at the end of 2020 into 2021 that we're now carrying over into the upcoming plan year. So that funds a few of those extra projects there. Okay, so those are the Kaiser HMO rates. Kaiser part-time HMO rates, again, increasing at the same rate as the other ones. On the top, we have the HEM, bottom we have non-HEM. Then we get into the deductible, so the Kaiser deductible. So we have the full-time on the top, full-time HEM, and then on the bottom table, we have the full-time non-HEM rates. And then for the part-time plans, we have, again, the HEM and non-HEM rates. HEM is the top table, non-HEM is the bottom table. Okay, so the MOTA, moving on to MOTA. So first of all, we want to get into an overview of the administrative fees, reflecting sort of the final outcome of the best and final renewal offers that MOTA and Providence, for that matter, provided at the last board meeting. So as a reminder, MOTA did come to the table with a rate pass and their administrative fee for this upcoming plan year. That was a savings to PEB of about $190,000 compared to where they were coming in at. And so we have on the left-hand side sort of their core offering. This is their medical, administrative offering. On the right-hand side of the page is for MOTA 360. And as part of MOTA 360, they have fixed costs. So that's where this, $4.51 dollars comes in at. And then on the variable fees, it's based on participation. So for members participating in the diabetes program through Livongo, for instance, it's charged on a per participant basis. And then also there is the 46-cent charge that will now be for dental and the dental integration piece that was approved. Okay, and then here are the subsequent accrual rates for MOTA. Full-time HEM and non-HEM is on the top. Part-time HEM and non-HEM is on the bottom. Okay. Moving on to Providence, we have the statewide and choice fees. So similar to MOTA, we just wanted to remind the board where the administrative fees came in as of the best and final renewal offers from Providence. Statewide remain the same as what Providence had originally proposed for the 2022 plan year. For choice, they brought it down by $1.50 PEPM. And $1.50 on the choice plan results in about $340,000 worth of savings to PEB. So certainly not insignificant. We called your attention to three lines. We already mentioned one. So number one, again, the move to Cigna and Clear Health for the out-of-network and out-of-area claims repricing. For number two, Providence has insourced their behavioral health administration. So they had a previous arrangement with Optum, so that has gone away now. And then finally, Mitch and Margaret and Ruby and all of them are working on the performance guarantees with all the carriers. So as actually part of that, we removed the triple aim incentive that has been in the Providence contract for a number of years since the last medical RFP. And so they actually moved those fees into a combination of the base administrative fee and some of the medical case and disease management components went up as well. So that component now goes away, but it's being caught in different buckets now as we look to do alignment of the performance guarantees across all carriers. Okay, the statewide plan is up first. So this is Providence statewide. We have the full-time HEM and non-HEM on the top. In the middle section, we have the part-time HEM and non-HEM. And then for choice, similar. So on the top, we have full choice, full-time, hem, and non-hem. And then we have in the middle section, the choice part-time, hem, and non-hem. And I think that's it. So if we want to do a motion to approve the medical, we can.
All right.
So this is Siobhan. I will make a motion that we approve the medical rates as presented.
Thank you. Do I have a second?
This is Kim Harmon. I second.
Thank you, Kim. Do I have any questions, comments?
So one thing I just wanted to flag, and this is more to PEB staff, but it looks like the MOTA rates are going to be lower than the Providence rates, and that will have an impact on folks who choose the lowest cost plan for our universities because they pay a 3% premium share. So, you know, that's just something that will need to be paid attention to for the 2022 plan year.
Thanks, Mom.
Thank you. All right, we'll go ahead and vote. Let's see. So Kate's still not here, or Kate appeared, sorry. Kate's here.
Yes, I'm back. Yes, I approve. I vote
Thank
yes.
Well, I'm running all these lists and Dana
I
is
know.
still gone. So, and then Kim was the second. Sean Parkman,
Yes.
thank you. And Mark Perlman, were you able to join us? No. And Siobhan was the first. Jeremy Vandehay,
As Jeremy, vote yes.
thank you. All right. So I think we have enough, correct?
Yes, that's correct.
Okay, perfect. All right, so it looks like that motion carries to accept the medical rates as presented and then be aware of the MOTA Providence, the impacts to universities. Okay, on to dental rates.
Yep. So this next section kind of summarizes dental and vision. So up first, we have Delta Dental of Oregon, or MOTA Dental. So we have 4 tables here. So the top one is just the administration fees. So small increase, about 10 cents PEPM, or per member, per employee per month. And then the bottom 3 tables are going to be the rates for the Premier Plan, the PPO, and the part-time. So just a small increase there of about 2.8%. And again, these are prior to PEB admin and consultant commissions. The next set are going to be Kaiser. So full-time is going to be the top table, and then part-time is going to be that bottom table. And again, no rate change here. Willamette Dental Group is next. Again, no change, similar to Kaiser, so same rates for full-time, part-time. And then we just wanted to call out here that for 2022, Willamette is waiving the office visit copay for new patients to help get that preventative utilization in. Up next is VSP, so Vision Service Plan. So up at the top, we just wanted to call out that there was a little bit of savings on the administration fee, so about 4 cents or about $20,000 annually. And then just a small decrease to the rates for the base plan and the plus plan. And then again, the only plan change here is adding that vision therapy for 2022. I think that was it. The next slide.
That should be it. Yep.
Quick one.
This is Siobhan. I'll make a motion that we approve the dental and VSP rates as presented.
Do I have a second?
This is Sean. I'll second.
Thank you, Sean. Any questions or comments about dental or VSP rates as presented? All right. Kate Nass,
Yes.
Kim Harmon.
Yes.
Thank you. Sean, second. Mark Perlman. No. Siobhan first. Jeremy Vanderhay?
This is Jeremy. Vote yes.
Thank you. All right. Looks like any opposed? Looks like the motion carries. Thank you. Thank you, Mercer.
So we just want to call out at the upcoming board meetings on our plans. So what we'll do now that we have final decisions, we'll confirm coverage with all the carriers. We have a number of items that we work with PEB staff on as far as delivering rates and reviewing, upcoming renewal documents and benefit summaries and whatnot. So we'll work with Ali and team on those. And then at the July board meeting, so we get to take June off, or for the most part, we get to take June off. But for July, we'll plan on doing an updated utilization report. So tis the season. We do have updated 2020 data. So we've kind of been collecting feedback over the course of the last few months over the renewal cycle, and we'll hope to present a really nice and useful utilization report that helps to address some of the underlying cost drivers associated with each of the plans. And then we'll also do an updated risk-based capital reporting in July based on all of the decisions and the final assessment that we have. And so with that, I will defer to Rose and Kimberly and whatnot, but I will stop sharing.
Thank you so much. All right, let's see. Oh, look at you guys. You bought us 3 minutes. So there was no break baked into this agenda. Do we need to take a really fast break? What do you all want to do?
Yeah, break would be great.
Okay, let's take a quick one. I think we can make it up. So 10 minutes, y'all. Stretch, break, water, and then 10 minutes. Thank you. And then Heidi will be ready to start with you. Thank you.
Hey, Kim, I see your face, so I'm going to pick on you for a second. Hey.
Problem. Hi.
I have to run, so I don't think I'll be able to be back. Do you need me me for quorum? I just have an 11:30 that I've got to run to with. I'm like triple booked today. It's one of those days.
I totally get that feeling. So technically,
I wanted to be here for the
it's
plan.
nip and tuck, right? So
this is Ollie. I think we're okay, Kate. Kimberly can always vote.
True.
So
okay.
Thanks, though.
No, thank you. I appreciate it. It's kind of crazy right now with the federal
Ali.
guidance and everything. So I'm being pulled in every direction.
Yeah. Oh, well, we appreciate that you were here this morning as long as you were. Thank you.
No, I wanted to be part of the plan approval piece. I wanted to have that there. So, okay, cool. Thank you, everyone. Have a good day for those listening. Bye.
See you.
See ya.
If we can get Heidi queued up, are we going to share our screen with her, Rose?
I think Heidi wants to share her own screen.
Oh, perfect. Perfect. Thank you.
Is she on?
Yes, I'm here. I did submit the slide deck.
Okay. Do you want to share your screen, or I can bring it up? It's their way.
Sure, if you could.
I thought you said you wanted to. Okay. No
oh,
problem.
no.
That's easy to do.
Thanks.
Thank you, Rose.
Just tell me next slide when you're ready, Heidi.
Okay, are we ready to go then?
Yes, we're
Can
back.
you see my screen?
We'll get started. Thank you.
Okay, great. Oh, go ahead.
Can you see the screen?
Yes, I can.
Can you see the slide? Okay.
Great, thanks. Good morning. My name is Heidi Murphy, and I'm the operations manager for the Oregon Prescription Drug Program. OPDP provides the pharmacy benefit program in collaboration with Moda Health for PEBB members enrolled in Moda plans. And thanks for providing the time today for me to give you just a brief update on the status of our transition activity to a new contract for pharmacy services for PEBB and its members. Joining me today in this discussion is Robert Judge. He's Moda Health Director of Pharmacy Services, who's available to answer any questions that come up regarding the status of our transition, if there's any deeper clarification needed at all. Next slide, please. My discussion today will cover the topics outlined in the agenda. OPDP will be starting a new agreement for the services that we provide using Moda Health starting January 1st, 2022. This new agreement includes several new elements that I'll cover in order for the board to have the information that you require to guide your decision-making moving forward.
Did she go mute?
Oh, I'm sorry. Can everybody hear me?
We can now.
Yeah. I'm so sorry. My name is Heidi Murphy, and I'm the operations manager for the Oregon Prescription Drug Program. OPDP provides the pharmacy benefit program in collaboration with Moda Health for PEBB members enrolled in Moda plans. Thanks for providing me the time today to just give you a brief update on the status of the transition activity to a new contract for pharmacy services for PEBB and its members. Joining me today in this discussion is Robert Judge. He's Moda Health's Director of Pharmacy Services, and he's here to answer any questions concerning the status of our transition should you need any more deeper clarification. I'm going to just cover the topics outlined in the agenda. OPDP will be starting a new agreement for the services that we provide using Moda Health starting January 1st, 2022. This new agreement includes several new elements that I'm going to cover in order for the board to have the information that you require to guide your decision-making moving forward. And I'll keep my comments relatively brief so we have time at the end to answer any questions that come up. I just want to provide a little bit of history. PEBB joined the OPDP program, which is part of a multi-state collaboration called the Northwest Prescription Drug Consortium in 2014. Joining OPDP allowed PEBB to benefit from significant price advantages that the Northwest Consortium provides. MOTA has administered the OPDP program and provided the pharmacy benefit services for this program since the consortium was created in 2007. And as a state entity, we are required to conduct periodic RFPs to ensure that we provide effective stewardship of taxpayer monies. And our most recent RFP was completed in 2020 with an effective start date beginning January 1st, 2022. MOTA was selected as the OPDP administrator following the RFP, and they'll continue in that role for the next 5 to 10 year contract cycle. Contract improvements include more aggressive pharmacy network financial guarantees and additional service options. A significant change in the new agreement is that MOTA will be changing its subcontracted back-end pharmacy benefit manager from MedImpact to Navitus Health Solutions, and MOTA is currently executing on that transition plan right now. In order for PEBB to operate under the new OPDP contract using MOTA, PEBB will need to complete a new pharmacy contract, which we call the Participating Program Agreement, or PPA. Next slide, please. This diagram is intended just to explain what I mean by a new back-end pharmacy benefit manager. The new OPDP agreement requires MOTA to transition PBM back-end services from MedImpact to Navitus. Services involved in this transition would include things like the claims processing system, pharmacy network, traditional PBM rebate management, and these services are depicted in the purple and orange boxes that you see beneath the triangles on this slide. As the benefit administrator, MOTA will continue to provide all the client and member-facing pharmacy benefit management services today. Some of those include like the clinical programs, which include formulary management, utilization management, and prior authorization. Member services, including local support services, their member call center, and open enrollment support, as well as specialty pharmacy fulfillment through its local specialty pharmacy, Arden Health. So while there's some changes for members as a result of the member-facing services provided currently and continuing with MOTA, we expect there's going to be very minimal impacts on its members. Next slide, please. So this slide summarizes the most important changes occurring as a result of the new OPDP contract. And I've spoken to most of these already. Next slide, please. An important consideration for PEBB is the timing of the new OPDP agreement start date and the start of PEBB's benefit plan year. PEBB's benefit year runs October 1st through September 30th, while the new OPDP contract runs on a calendar year basis starting January 1st, 2022. While the new OPDP contract begins on January 1st, under certain circumstances, the OPDP program can be available to accommodate the start of PEBB's benefit plan year. So this slide depicts the transition timelines that can coincide with either of the start dates. We're confident that MOTA's transition plans can meet either the January 1st or an October 1st go live date if the PEBB board makes that request. Next slide, please. So as I mentioned, while significant changes are not expected with MOTA's transition to a new PBM subcontractor, any transition does come with some change. So as PEBB considers its options, this slide depicts areas that we believe are relevant to any decision you'll make, as there's potential impact on these elements depending on the date that the OPDP contract becomes effective. Advanced communication, outreach, and in some cases, grandfathering of certain provisions may be applied to ease the impact of a transition, regardless of when PEBB transitions to the OPDP contract. And I just want to stress that neither OPDP nor MODA have a preference in PEBB's consideration of these items. While we're preparing for a January start for our new agreement with MODA, we can work with PEBB to accommodate a start date requirement that might be different. Next slide, please.
Hey, Heidi. Heidi, this is Robert Judge.
Yeah.
I just want to, I think there was maybe some confusing information that was presented here, and I just want to clarify for the PEBB board. So, the PEBB board runs January to December. The current path that we're on is a January implementation for PEBB. I think you referenced an OEB start date of October 1. Which,
oh, I'm sorry.
They've made a decision to proceed on an October 1 date. So the current plan of record is a January 1 conversion, and we've got our implementation team working towards that timeline to make it happen.
Right. So in order for the new OPDP agreement to be used by PEBB before the January 1st, 2022 date, we're just required to notify, PEBB will be required to notify OPDP and MODA as the OPDP administrator in writing that the needs can't be met under the terms of the current PPA. So if this scenario is what PEBB chooses after we receive formal notice from PEBB, we'll require that a new PPA be executed before October 1st, 2022.
Well, I think January 1st works for us. It aligns with our calendar year plan year, so that works for us.
Okay. Are there any further questions that anybody has?
Yeah, this is Sean. Just kind of a detailed question. This program, does it accommodate mail order pharmacy delivery? Or is it agnostic to that?
Heidi, would you like me to take that?
Oh, go ahead. But we do use PPS for mail order.
Yeah. So there are two options. There's PPS is your incumbent today, and it's available to all members who want to use a mail order pharmacy to fulfill that. That's Postal Prescription Services, and it's based in Portland. The other option is Costco mail order facility, and they have multiple locations on the West Coast, up in Kirkland and then down in Corona. And then, of course, as with Postal Prescription Services, they have locations in other parts of the country for members who might be elsewhere.
Okay, thank you. My question there was provoked by one of the slides just talking about network access and that sort of thing, and where I was thinking about our rural members. So
right, yeah. So I think the best way to think about that is that in terms of network alignment, there's really intended to be a minimal shift at all. We're trying to rebuild the same network under Navitas that we have today under the incumbent with us, MedImpact.
Okay, thanks for clarifying.
Sure.
Thank you so much, Heidi. And
yeah, thank you
for joining us.
I appreciate the time.
Thank you. Looks like we are ready for Brian and Claudia to cover the consultant RFP.
And I know this is Brian. Claudia was having some technical difficulties earlier, so if there's instructions for her how to mute her phone or unmute it, we may need to give that to her verbally right now.
You already sent that to her, Brian.
I think I was on a master mute.
Oh,
can you
you're
hear
on
me now?
Yep, we can hear you, Claudia.
I heard there was some feedback, and I heard something happen that said you are now on mute. Press *6. So I wrote that down and it worked. So I'm not muted anymore. Thank you.
Perfect. I'll turn it over to you, Claudia.
Okay. This is Claudia Grimm. Brian came before you last month with a consultant RFP update. I am here because we've had now an opportunity to present to the OEB board. We've also had time as the contracts team, including our newest member, Ruby and Sheila, to do some more work on the RFP. So I really don't want to rehash things that haven't changed, but my purpose here today is to tell you a few things that have changed, and then at the end of this presentation to request specific action by the board to release the RFP. And I'm gonna rely on Rose to drive the presentation, and I have some prompts and cues for where I am in the project. But right now I am going to the middle of page 2 to the leadership group. And the purpose of the leadership group has not changed. It's to provide strategic direction and advice, policy advice, but based on some conversations that have happened with our OEB PEB leadership and different members of the board, we are now proposing the following leadership group membership, which is the OEB and PEB director, the OEB board chair or designee, and the PEB board chair or designee. So that's an update since last month. Selection committee, we've had some conversations, or Ali and Damien have had conversations with board members. Last month when Brian presented, we were hoping that we could get 6 members from each board to serve on the selection committee to score not only the questionnaires, but also the interviews. In the event, this is now I'm on the second paragraph under section 4, page 2. In the event that fewer than 6 members from each board can participate on the selection committee, staff will work with the leadership group to implement the appropriate solutions, which could mean fewer than 6 members from each board serving on the selection committees, but there would be equal representation from both boards. So if the number was 5, it would be 5 members from the PEB board, 5 members from the OEB board. So that is a little bit of a change. We've flushed out now at the bottom of page 2 the different kinds of questions that staff may, our PEB and OEB staff may score, as well as on the top of page 3, looking to our subject matter experts at the Oregon Health Authority, Health Policy and Analytics, more than specific subsets related to diversity, equity, inclusion. There's also specific types of technical and regulatory work related to reporting that have to do with General Accounting Standards Board, GASB, all payers, all claim database, as well as some of the questions related to proposer data warehouse scoring. So moving on down the page, evaluation and scoring of proposals and interviews, number 5. Just to give you a flavor of what we would be asking the board to score, the bulleted points are questions about organizational structure, staff expertise, and cost proposal, those categories of questions. Now that we're flushing out the questionnaire, really call for some board expertise. Nothing else in that section has changed. And as we go to the interviews on page 4, the top of page 4, one of the things that came about at the OEB board meeting is that we now envision the interviews will receive a heavier weighting with regard to the overall score. because they are a critical point in the process where the board is looking at the consulting staff and trying to determine a fit, whether communication is clear, etc. So that's a little bit different approach, and I wanted to call that to your attention. One of the things that Ali did bring to Brian and my attention is with regard to what is going to be the time commitment for all this. And I know, especially as board members, vacation schedules, people are being vaccinated. It's the middle of summer. The RFP is still being proposed to be released the first week in July, which it is. What would be the time commitment? And at this point, for scoring of the questionnaires, we do not envision more than 10 to 12 hours total for all the proposers combined. That's only the scoring of the questionnaires. When I looked at what the interview schedule looked like in 2014, I can tell you that there were 4 proposers that were invited to interview, and that the interviews were an hour and a half in length for the presentation, Q&A, etc., and then an additional 30 minutes for discussion amongst the entire board, which is invited to participate, and final scoring by the selection committee. So each interview was approximately 2 hours. So when you're thinking about time commitment, those are the parameters around the time commitment. Before we get to the requested action, I do want to note that for the RFP milestones, those have not changed since Brian presented. We're still looking for tentatively a July 1 release date, depending on DOJ final legal sufficiency approval to release the RFP. And with that, we are requesting specific board action today, and that is approval to release the RFP and work with staff and board leadership to finalize the roles as I have outlined them and described them in this document. But before we move to, I turn it over to Kimberly for requesting that formal action, I just wanted to open it up for any questions that you may have. I went over everything very quickly. If there's anything from Brian's original presentation or my presentation today that begs further clarification, I would like to open up the time now to answer any outstanding questions.
And Claudia, this is Ollie. I just wanted to add, since OWEB has 12 board members, PEBB has 8, with Dana on COVID and Kimberly on the leadership team, that leaves 6. So as Claudia mentioned, we reserve the right to reduce the number. You know, ideally it would be nice to have all 6 available to do the scoring proposals and review, but we are realistic. So, I mean, even talking with OWEB board members, it's going to be tough to even get there out of their 11 that are available. So we'll talk more about that, but I don't want to put a tremendous amount of pressure right now on PEBB board members.
Thank you, Ollie.
Yeah.
Anything else before I turn it over to Kimberly, your board chair? Okay, thank you. I guess you can take it from here, Kimberly.
Thank you so much. And thank you all for all the hard work you've done on preparing this RFP to get to go out there. So it looks like I need a motion.
This is Siobhan. I'll make a motion that we release the RFP and then work with staff and board leadership to finalize the RFP roles as described in the document that Claudia just went over with us.
Thank you. Do I have a second?
This is Jeremy. I'll second.
Thank you, Jeremy. Any questions or concerns? All right, we'll do a roll call. So Kate had to step out. Kim Harmon.
Yes.
Thank you. Sean Parkman.
Yes.
Thank you, sir. I'm still rooting for Mark Perlman. Mark Perlman. And then Siobhan made the motion. Jeremy second.
You'll need to vote here, Kimberly.
Who is?
This is Ollie. You'll need to vote here.
Oh, thank you. And I vote yes for releasing the RFP. Any opposed? Looks like the motion carries. Thank you so much for all that hard work.
Thank you all. I appreciate it.
Rose, did we have any public comment today?
No, there's no written public comment, and no one's let me know that they want to say anything unless somebody's on the line.
Thank you, Rose. Looks like no one spoke up. So it looks like we have had a very busy and successful PEB board meeting. Thank you all so much for being here. Ali, did you want to talk to us real quick at the end about figuring out when?
I do. Thank you so much. Yeah, so this is related to a vaccine incentive. We had an inquiry from the governor's office a few days ago, seeing if the PEB and OWEB boards have any interest in offering a vaccine incentive. As you may have heard, the goal is to get 70% of eligible Oregonians at least one vaccine shot by July 1st. So staff has been working on pulling options together. It definitely takes some time to work through how we would get the completion data, which is PHI, private health information, and some of the other privacy issue, ADA considerations for reasonable alternatives, and then just a legal review by DOJ. So currently staff has looked at a cash incentive similar to a HEM incentive, a reduced premium share or deductible, and then on-site workplace vaccine clinics like Providence talked about earlier. And, you know, we've even talked about a lottery similar to the state of Ohio or an additional PTO time or day, which those last two options obviously would be statewide kind of endeavors, which would involve DAS rather than PEB. So, but the options are kind of endless. The administrative challenges are definitely there as well. But there's currently only one state health plan offering an incentive. It's actually the state of Maryland. I'm part of a listserv of directors of state employee health plans around the country, and Maryland was the only one. And I actually got a chance to talk with their director, and they're offering a $100 incentive to employees who complete their vaccination and provide proof. That's probably the leading option with staff right now based on equity. If you were to offer it to all employees who have completed their vaccination, not just the ones that have not. But it's a significant amount of money, of course, and you know, we want to look at something that would get members to act. It wouldn't make any sense to do something that's going to be complex and expensive if it wouldn't really get members to take action. So we've engaged our carriers in this as well. So, you know, we'll be working over the next week or two to bring some options to the board. And I guess right now what I'm looking for is just, you know, consent from board members that they would like us to pursue this. And obviously we all share similar goals of getting the population to that 70%. So whatever we can do to help, whether it costs money or not, we'll definitely do. But that's what I'm here to ask for today.
So I just wanted to make a few comments on this. I mean, I do think that certainly us doing our part to encourage the vaccine hesitant. I know that there are going to be a lot of different methods to encourage different people, and it's not a one size fits all. I'm hearing you say that the incentive amount you know, that's the leading idea among staff right now, because it's the most equitable to give everyone a set dollar amount. And I know that, I mean, I've seen research recently, I think it was reported that it was a $100 incentive, similar to what Maryland's doing, does incent some people to get vaccinated. And so I think that's good for us to be looking at that as well. And it sounds like the board will continue to look at different options. And so, Ali, are you thinking you would present back to us? I guess I worry a little bit about quorum getting us together, or whether we should empower staff to work with our chair and vice chair, with Kimberly and Sean, around making a decision.
Yeah, if the board wants us to move forward, we'll pull some options together. We can either work with board leadership to move forward with an incentive, or we can schedule a special board meeting in the next couple of weeks that would be a short board meeting, 10 to 15 minutes. So either way, we'll work through all the information that I talked about earlier as far as data, and make sure when we bring an option to the board or work through board leadership, that it's something that we could do and do it safely and legally.
Well, I'm willing to make a motion that we empower the staff to work with our board leadership around the options, and as part of that, that that the board leadership would communicate with the PEB board, but we would leave the decision making to the leadership and the staff, so that we don't have any issues around quorum.
Ms. Jeremy, I'd second that.
You all are so well trained, I don't have to do anything. No, so we have a motion on the floor. So I am going to go ahead and we'll take a vote. Or any questions about the motion? Okay, so we've got Kim Harmon.
I agree, yes.
Thank you. And then Sean was the second. Saban was the first, or sorry, Saban was the first. Sean, sorry, I'm getting my list mixed up. How do you vote, Sean?
Yes.
You and I can get with Ali and the leadership PEB. Okay.
Yes.
Thank you. Siobhan was the first. Jeremy was the second. And then I believe I have to vote again, correct? So yes, I support us empowering the PEB staff, and then getting back with Sean, and I will make ourselves available. And so the motion carries unless question, concerns, opposed. It looks like I run off a script, so I'm off a little bit. Okay, looks like the motion carries. I just wanted to add one thing. So Department of Corrections is also really trying to up the numbers, and it sounds like we've got or going to have some J&J coming up very soon, and we are actually going to do family days to help get the families into the prisons and offer shots for the age groups that are now allowed, and really try to help up those numbers and make it easy for people, that they don't have to go to a pharmacy or get in line somewhere. The actual institutions where the staff work are going to offer these shot fairs, so vaccination clinics. Anyway, that's all that I had for that piece. Ali, did we need to, are you going to schedule a little quickie date for, did we have one other thing that we'll have to talk about later?
No, I think we're okay. I think we have everything we need to move it forward. Thank you.
Okay. Okay. So good meeting. Thank you all so much, and be safe out there, and continue to take care of yourselves, wash your hands, wear your mask, get your shots, do your dance. And thank you all so much for being here. And thank you so much to our presenters. Great work. Thank you for staying on time. And we appreciate all of you. And thank you, Rose, for being our cheerleader behind the scenes. Thank you all. Bye. Meeting adjourned.
Thank you.